Okay, thanks very much. So I'm going to really just give an outline on infections and lung transplant recipients. I think I'm going to give a bit of a background on what lung transplant is and how it works in Cape Town at least. But the important thing to say is I'm not going to come to an ID audience and tell them about opportunistic infections and solid organ transplant recipients. I'm sure you know that all very well. So I'm going to focus on some of the things that make lung transplants unique among the solid organ transplants, and then hopefully Ashley can tell us about some of our experiences. So the first thing to say is that lung transplant is the option of last resort for patients with end-stage respiratory failure of whatever cause. And it's a therapy that both improves quality of life as well as improving lifespan. And most patients who survive the first 30 days end up at the end of the first year with normal lung function. So it can be completely transformative. And in the US, at least, the data shows that most of those patients return to some form of gain failure. So it really can be a revolutionary therapy, but it comes with lots of problems. There are lots of challenges. Firstly, lungs are often involved in the mechanism of brain death, so neurogenic pulmonary edema or aspiration from patients on a ventilator. So the procurement rates of lungs from a deceased donor are much lower than that of solid organ transplants. For example, the liver is usually retrieved in about 50% of cases, the kidneys in about 80% of donors, and lungs will really only be able to be harvested in about 20 to 40% of patients. So you can see that already puts donor shortages on the horizon. There's often complex post-op ICU care involving the use of something called ECMO, which I'm sure all of you know about, extracorporeal membrane oxygenation, so mechanical support when the lungs themselves are not working immediately because of primary graft dysfunction. The surgical technique is quite challenging. As I'll show you in a few slides, the long-term outcomes of lung transplants are worse than those of other solid organ transplants. And then two very important points which we're going to discuss in quite a lot of detail. Firstly, it's the only transplant where the allograft itself is in contact with the outside environment. And that's very important because the immunological barrier becomes much more critical. And also the amount of immunosuppression that lung transplants require is higher than that of other solid organ transplants. So there's a requirement for lifelong and pretty intense immunosuppression. Nevertheless, this is a therapy that's rapidly gaining traction. This is an old slide now from the International Society for Heart and Lung Transplantation Registry. But just to show that year on year, the number of lung transplants performed around the world is increasing, and it's well over 5,000 transplants a year at the moment. And it's growing all the time, and it's in the stark contrast to heart transplants, for example. The advent of durable left ventricular assist devices, or LVADs, have really reduced the amount of heart transplants that need to be done internationally. Of course, those lung transplants are disproportionately being done in North America and Europe. Only a very small number of centers, mainly in Australasia and in Hong Kong, still doing transplant outside of those major areas. They're really just this geographical map showing that really there's only South Africa that's really doing lung transplants in the whole of Africa. There are two centers. One is the Mill Park Hospital in Johannesburg, and they obviously only do insured patients. That's a Netcare hospital. And then Prof, where we offer lung transplants to both public sector as well as patients on medical aid. So we've got a joint program across those two centers. These centers are about 1,400 kilometers apart, which means that we don't compete that much for organs because of the fact that cold ischemic time is an issue and transport is an issue. And so regional allocation really takes it's really the strategy that most of us employ. Just to talk about thoracic transplantation in Prof, well, I probably don't need to remind our audience that we've got a historical, very impressive pedigree for transplantation at this institution, with the first heart transplant being done in 1967. And at the height of the 1980s and 1990s, Prof was one of the busiest heart transplant centers in the world, doing up to 35 transplants a year. As you can see, with the disinvestment that happened with coronary care, and there was actually a moratorium on solid organ transplant in the early 2000s, that dropped off quite a lot. And it's really been it's the lung transplant program that we're hoping is going to reinvigorate thoracic transplantation at Prof. This is our activity so far. We've done 230 assessments. We've waitlisted 72 patients, and we've done 49 transplants in the last 3 years. So that's our transplant activity. And about 3/4 of them have an uncomplicated ICU stay and go to the work in 7 to 9 days. What are the advantages of a lung transplant? Well, if it works, you've got normal quality of life, normal lung function, no limitation to effort tolerance. You can return to work, and particularly if you're a patient who's got cystic fibrosis or a form of bronchiectasis, then you've obviously released from all that complex airway clearance regimen that you have to do twice a day and all the nebulizing, etc. What are the disadvantages? Well, there are no guarantees of suitable donors. It's risky surgery. There's intensive follow-up, like with all transplants, but particularly because of the intensity of immunosuppression. It's a lifetime of working the tightrope between rejection and infection. And then there are lots of non-infective long-term complications, of which cancer is probably the most important. So I'm going to quickly talk about the major indications for transplant, and hopefully I can just narrow down now on infections. But the indications for lung transplantation differ if you compare single lung transplants to bilateral lung transplants. So overall, the commonest indications for lung transplants are COPD, pulmonary fibrosis of whatever cause, so interstitial lung disease, and then cystic fibrosis. That epidemiology is being rapidly altered by the advent of high levels of CFTR modulators. So these are drugs that work against the cause of cystic fibrosis. And the number of patients transplanted for CF, especially in America, has gone down dramatically over the last year or two. But the important thing to say is that whenever you've got infection, so you've got bronchiectasis or cystic fibrosis, then you have to do a bilateral lung transplant because you can't have an allograft with an infected lung on the other side. So that's why you can see the dark blue, the CF, there are very few patients who undergo single lung transplantation, those indications. So this just speaks to the importance of native organism colonization when it comes to the transplant. So what are the unique factors? I said I was going to focus on what makes lung transplants unique in a solid organ transplant arena. Well, firstly, as I said, there's direct airway exposure. So there's constant contact with external antigens or pathogens, excuse me. So you probably don't know this, but if you look at your alveolar surface area, it's 70 square meters if you have to spread it out. So that's half a tennis court. So your lungs are by far and away the biggest part of the body that's in contact with the outside environment, much bigger than your gut or your skin. But that barrier between blood and gas, your alveolar capillary basement membrane, is 0.3 of a millionth of a millimeter in diameter. So it's simultaneously the greatest surface area of your body, but also the thinnest barrier that's in contact with the outside environment. So you can imagine what that does for your infective risk, as well as the immunological barrier that has to exist to defend your lung. Also, in the surgery itself, there's disruption of lymphatic drainage. In patients with cystic fibrosis and those that have got infection, they've often massive bronchial arteries and lymph nodes that have to be removed in order for the anastomosis to happen. So there's impaired immune surveillance because you're directly impacted on lymphatic protection of the lung. You've denervated the lung, so you've lost your cough reflex. That does come back over several months to years, but there's impairment in your cough, and that means there's poor clearance of secretions. As I'll talk about later, one of the things that's interrupted by the suture line at the bronchial anastomosis is the mucociliary escalator. So patients that have got sputum production or have got phlegm are often unable to move that phlegm past the bronchial anastomosis, and so bronchoscopy becomes an important tool in clearing secretions early in the transplant period. Also, there's airway ischemia at the anastomosis, and this is a specific consideration. So bronchial anastomotic infection, the dreaded complication of a lung transplant is bronchiolitis. Okay, and as you can imagine, that's a really, really bad complication. And organisms like staph and aspergillus like to infect that very avascular anastomosis, and it's something that we've got to prophylax against, and I'll talk about that a bit later. And then again, for reasons that are not completely understood, there's a high immunosuppression requirements. So lungs are especially rejection prone compared to other solid organs, and we haven't really managed to immunosuppress lung transplants in a way that chronic rejection is never a problem. So I'll show you some data later on, but almost everybody develops some form of chronic lung allograft dysfunction, which is the physiological correlate to chronic rejection. And so high levels of immunosuppression are sustained throughout the transplant. And that's very different from a liver transplant, for example, where patients can quite rapidly wean off to minimal immunosuppression by about 6 months. So I've told you that the long-term survival is less than that for other solid organ transplants, and it's very important to stratify this by underlying indication for transplant. So for example, patients with cystic fibrosis, they're obviously generally younger and have got no organ disease outside of their lungs. And their median survival is between 10 and 12 years, with about 30% of them living up to 20 years. So those do the best. Whereas older patients, and in the United States, 20% of lung transplants are done in patients over the age of 70. That's almost incredible. And the majority of those have got COPD or pulmonary fibrosis. The median survival is only about 6 to 8 years. bearing in mind the actual survival of a 70-year-old is obviously really reduced. But this is really what I want to talk about, is something called chronic lung allograft dysfunction. So this is an umbrella term for two main pathologies. One is called bronchiolitis obliterans, and the other one is called the restrictive allograft dysfunction syndrome. So that's a pathology where there's fibrosis and scarring and restriction in lung volume. Both of them are measures of chronic rejection. Bronchiolitis obliterans is much more common because HLA antigens are most densely expressed on airway epithelium. So when you have chronic rejection, that's where the fibrosis happens. And if you have a look at we back it up one step. So the definition of FOS is if you've got a decrease in your forced expiratory volume in 1 second, or your FEV1, by 20% or more from the best baseline that you've achieved in the first year after transplant. So I've told you that at the end of the first year, the reason why we're waiting for the end of the first year is there are lots of conformational changes that happen in your cholesterol, remodeling, depending on what your underlying diagnosis was. And at that best level, everybody's lung function will drop to less than 80% of that value. So they drop by 20% in about 5 years. So if you look at the incidence of BOS at about 5 years, it's about 50%. If you look at 10 years, it's almost 80%. So this speaks to my point about everybody getting chronic rejection of some kind, as they progress in their transplant course. And what's the relationship between chronic infection and rejection? Chronic allograft dysfunction syndrome and infection. You have to talk about infection. So firstly, to say that CLAD, or chronic rejection, is the leading cause of late morbidity and mortality after lung transplant. So once you survive the initial infective period, this is what kills you. And unlike liver or kidney grafts, where chronic rejection is mainly immune-driven, in lungs, infections are a major accelerant of allograft dysfunction. And whether there's some pathogens where this is a direct effect, and there's other ones where they think that obviously the fact that you have a chronic infection in your lungs kind of alerts your immune system to what's going on there and brings some of the T-cell mediated effects to the lung epithelium. Also, respiratory viral infections, and we'll talk about these in a little while, they can trigger acute rejection. And even infections like influenza or rhinovirus, they cause denuding of the alveolar, the respiratory epithelium, and that exposes so-called cryptic or non-HLA antigens in the pneumocytes, and that can also precipitate rejection. And then lastly, chronic colonization of Pseudomonas or Burkholderia increases the risk of CLAD significantly, again, probably because of some kind of immune activation. Fungal colonization, particularly with Aspergillus, is also a risk factor. And so therefore, when you're looking at CLAD-free survival, this is, I think, one of the aspects that make lung transplants unique. You're not only talking about optimizing immunosuppression, but you're also looking at preventing infections as much as possible. And that we're going to talk about in a few slides. So the timing of infections after transplant are very different. So you can see that early on, the bacterial infection is usually from some kind of nosocomial source or donor-derived. So patient donors are often on ventilators for several days. They obviously can develop VAPs, ventilator-associated pneumonias. They become colonized with bugs. They may have aspirated, so you can transplant lungs with bugs. They can get lung infections in the ICU. As you go further down the line, and the risk of those infections goes away, you can have reactivation of CMV. You can get colonization and infection of fungi from the environment as patients move into their homes. And the risk of bacterial pneumonia or tracheobronchitis really just stays present for the duration of the lung transplant course. But this is really the sobering statistic. Opportunistic infections are responsible for 30% of deaths in the first year after transplant, and then overall 20% thereafter. So they're an important cause of morbidity and mortality. When we try and work out epidemiologically what kind of infection we're dealing with, it's important to divide the time periods. It's kind of alluded to in the previous graph. But we talk about early infections, which are going to be donor-derived. They can be surgical, like wound site sepsis, anastomotic infections. I've spoken about those. And obviously, those are much more common in kidney and heart and liver recipients where the anastomoses and where the surgical sites are interior. And the intermediate period, which is 1 to 6 months, the opportunistic pathogens similar to other solid organ transplants, but usually of higher frequency or severity. And here the two important ones are going to be CMV pneumonitis and invasive aspergillosis or Aspergillus tracheobronchitis. And then lastly, later than 6 months, respiratory viruses are much more important than in other solid organ transplants for the reasons that I mentioned and their propensity to stimulate rejection. And they're also disproportionately severe in lung transplant recipients. And we saw this in the COVID pandemic. And then, as I said, they're linked to chronic lung alveolar dysfunction and also CMV reactivation. So there's a link between respiratory viruses and CMV. Bacterial infection, well, this is important in patients like cystic fibrosis where there's pre-existing colonization. And they can often harbor drugs like MDR, Pseudomonas, Burkholderia, and Stematophimonas. Of course, by explanting the native lungs, that is a source control procedure. And so we often get rid of the majority of bugs, but remember the trachea stays colonized, and in cystic fibrosis, there can often be significant rhinosinusitis, so there are reservoirs for these bugs going forward. I've spoken about airway ischemia and an anastomotic infection risk, which is obviously unique to lungs. And you can get chronic bacterial airway colonization, which leads to recurrent infection and is a risk factor for CLAD. And this is obviously in contrast to other solid organ transplants where there's very rare chronic bacterial colonization. And we do see it in some of the more complex biliary surgeries that happen in liver transplants. Obviously, patients with this urological problem can get chronic reflux nephropathy in a renal allograft, but generally it's much less common. What about viral infections? Well, the prototypical infection to worry about here is CMV pneumonitis. Obviously, any transplant patient could get CMV pneumonitis, but lung allografts are much more susceptible. It's obviously a reservoir for CMV. There's a strong association between CMV reactivation and acute rejection, and obviously also CLAD. Spoken about the community-acquired respiratory viruses. These can cause life-threatening pneumonitis, often mild in kidney and liver recipients. And then there's the entity of EBV reactivation and the incidence of post-transplant lymphoproliferative disease. So this occurs across solid organ transplants, but the airway is actually a reservoir for EBV and chronically shed in. And this is a site of viral replication. And it's thought that the viral replication plus the local cytokine formation acts as a cofactor in PTLD risk. Also, because of bronchial associated lymphoid tissue, so belt. And there's also an airway-centric disease where it can mimic other forms of infected pneumonitis. And that's, again, a presentation that's much more common than in other solid organ transplants. Fungal infection, well, I probably don't need to tell this audience anything about aspergillus in the lung, but just to say that it's a much higher incidence than other solid organ transplants, and the incidence of invasive fungal disease in lung transplant recipients is 40 times that of a renal transplant recipient. So it's much more impressive. I've told you about airway and anastomotic infections. As I said, aspergillus, dehiscence of the bronchial anastomosis is a dreaded complication. You often have secondary mediastinitis, and it's almost an unsurvivable complication. You do get rare molds. We've seen this with our CF patients, colonization with Sceletosporium apiospermum, for example. And Candida, you do get airway colonization and can sometimes be invasive, again, usually at the avascular anastomotic sites. Other opportunistic infections, well, of course, pneumocystis is important. Consequences are more severe in lung transplantation, but we seem to be able to prophylax it for pretty easily for Bactrim twice a week. So we're giving on a Monday and Thursday rather than daily. We have quite a lot of problems with all the myelosuppressive drugs that we give, like the cell cycle inhibitors, like mycophenolate, and valganciclovir, which is also myelosuppressive, and Bactrim is an additive drug. So we find by giving it twice a week, it seems to prophylax well. We haven't actually had a case of pneumocystis in our units. Well, everybody's on Bactrim prophylaxis, and we get away with less myelosuppression without those drugs. And then lastly, there's nocardia and then mycobacterial infection, which can be non-tuberculous and tuberculous. And again, there's a higher burden due to airway exposure and pre-transplant colonization, especially in cystic fibrosis patients with Mycobacterium avium and Mycobacterium abscessus are very important. In many units, Mycobacterium abscessus is a contraindication to the transplant because it's almost impossible to eradicate. And you get a lot of skin and soft tissue infections, often at the wound, in patients that get transplanted with M. abscessus. I'm going to talk quickly about TB following lung transplantation. I think Ashley is going to tell us about some of the patients in our cohort who did contract TB. There's very little data from, firstly, let me just say that there are not a lot of countries in the world that are high TB burden settings that are doing lung transplants. So there's very little data on this. But there's two studies looking at the incidence of TB in lung transplant recipients, one from Spain that found 2,072 per 100,000 transplant years, and 4,750 per 100,000 transplant years. And this was a study done in Saudi Arabia. As I said, there are few studies from high burden settings. But in the Saudi study, which was a transplant registry of many solid organ transplants, they looked at the general population and found that the incidence of TB was 8 times higher than in renal, 8 times higher in renal recipients, 40 times higher in heart recipients, 42 times higher in liver recipients, and 339 times higher in lung transplant recipients. So you can see that this data certainly isn't robust, but it suggests a much higher risk. And of course, in lung transplantation, you can get TB 3 ways. You can get it from a donor, you can acquire it in the post-transplant course, and you can reactivate your own latent infection, because generally for most patients, your mediastinum and bladder lymph nodes are not removed, so you can have a reservoir infection there. So this is something that we've thought about quite a lot. In our setting, there really isn't any point in treating patients for latent TB before transplant, because we don't know what lungs they're going to get. I mean, it could just be as easily transplanting them with lungs that have latent TB. But the one thing we really want to try and not do is transplant lungs with active TB. So how do we look at that? Well, we obviously have to look at the radiology. We must ask about a history of treated TB. We've decided that if the patient's got evidence of fibrotic or calcified lesions and no history of TB treatment, then that's a contraindication. If you've got the presence of fibrotic or calcified lesions, obviously not ones that are significant enough to really impact on overall lung function, and a positive history of TB treatment, then that would really be at the discretion of the clinician allocating the lungs on the night of transplant to decide on the extent of lung involvement, and really, most importantly, I think, on the priority of the recipient that's going to receive the lungs, so how sick they are and how desperate they are. Those are the extended criteria for donor lungs. Of course, latent TB doesn't have any radiological changes. We can't really diagnose that on a donor before we go to theatre. A TST isn't practical. You can't do a TST and then go back and leave it 3 days later with somebody that you're going to take to theatre to retrieve their organs on. And IGRAs, although they are potential tests, there is some work showing that brain death is immunosuppressive and that donors have higher intermediate results, so it's possibly less reliable. So although it's attractive, it's probably something that also can't be relied on in the pre-transplant time. What about prevention of de novo infection? Yeah, well, there's none. There are no studies looking at lung transplantation, but we've kind of extrapolated from medium and high burden countries like Saudi Arabia and Pakistan. We've looked at renal transplants, and a meta-analysis from 4 RCTs show a reduction in TB with INH prophylaxis and a pretty impressive relative risk of 0.31. No increase in hepatotoxicity. At critical care, there's universal prophylaxis in the renal program. And in the liver program, they wait 6 weeks so that all the abnormalities in the liver functions can kind of settle before introducing INH. What do we do? Well, we have our main emphasis on excluding active TB. So we do a bronchoalveolar lavage or tracheal aspirate on all patients, on all donors. We have a low threshold for CT chest in potential donors, and we exclude those that have got radiological changes suggestive of active TB. And as I said, the inclusion of donors with radiological changes of healed TB are at the clinician's discretion, depending on the urgency of the patient. Just to say that this sounds all very good, but it's often impractical. If we've got a donor at a peripheral hospital or at a hospital in the Eastern Cape, maybe no CT facilities, there may be no bronchoscopy facilities. And we may go and retrieve the organs and do a bronchoscopy on table, but then we're returning with the organs and the bowel sample and having to make a decision kind of on the fly. Obviously, X-rays are relatively insensitive, and you'll probably hear from Ashley later that we have got it wrong on one occasion. Recipients, we don't investigate or treat them for LTBI. As I said, we feel like that's just redundant because we may be transplanting an organ that's got latent TB anyway, and you have universal prophylaxis with INH post-transplant. And what I can say is that we've transplanted a patient with active TB. We've had one patient with donor-derived TB who actually had his transplant in India and joined our program shortly. It was a South African who flew to India, had his transplant, and then came back after 4 weeks. And he had donor-derived TB, but we've had no cases of incident TB for our patients that have been on INH prophylaxis. So how do you diagnose patients with infection in the lung transplant kind of arena? Well, the bronchoalveolar lavage is a very important test. Gives you direct access to the allograft. And basically, it's the go-to test if anybody's sick at all or has got any new infiltrates. So we've got a very low threshold to do bronchoscopy. As I said, there's often a problem with producing sputum because of the interruption of the mucociliary escalator at the bronchoalveolar site. And there's a sutures there, and until that heals really well, patients often find it almost impossible to cough past that point. We also have a surveillance bronchoscopy protocol where we do bronchoscopies and biopsies at 3 weekly, firstly at weekly and then 3 weekly intervals through the first 3 months of the transplant. So we're looking for signs of colonization and we try and eradicate where possible. It can be quite difficult, particularly in patients who, as I've said, have got upper airway colonization, like those CF patients with chronic rhinosinusitis. It can be quite difficult to differentiate colonization from invasive infection, especially with fungi and bacteria. And then imaging is often unhelpful because there's a lot of overlap between the entity of primary graft dysfunction, which is kind of like an umbrella term for all of the things that can make your lungs not work immediately after a transplant, like a reperfusion injury, pulmonary edema, etc., and acute rejection. And so there's a diagnostic challenge which is not typical in other solid organ transplant recipients. So what do we do? Well, mainly try and focus on prevention. So we use antifungal prophylaxis. Universal prophylaxis is routine in about 90% of lung transplant centers, particularly in patients with CF. We'll get an azole, usually posaconazole, which we don't have available, or voriconazole. These drugs are a problem because they interact with the CYP3A4 system that metabolizes tacrolimus. So it often leads to problems with getting the levels right, and that's obviously a risk factor in itself for getting rejection. We use amphotericin B. We feel like it's a sort of something that's been shown to prevent anastomotic aspergillus infection, and it's an antibiotic obviously delivered directly to the airways. We have not used universal azole prophylaxis, but only in patients who pre-transplant or colonized with aspergillus. For those with post-tuberculous lung disease and had a few with aspergillomas, simple aspergillomas, and then obviously cystic fibrosis patients who've got aspergillus colonization. We use aggressive viral prophylaxis due to the high pneumonitis risk, and that starts immediately after transplant, although the incidence of CMV reactivation or infection in the first 21 days after transplant is very low. We give intravenous ganciclovir from the first day after transplant. Whether we're using preemptive or universal strategy largely depends on cost. Well, ganciclovir is very expensive. So we tend to use a preemptive strategy once we were outside of the periods of universal prophylaxis, and that depends on the durations of therapy depend on the type of transplant. So if you've got a donor positive, recipient negative transplant, then usually we extend universal prophylaxis to 12 months. Whereas if you're recipient positive, irrespective of if you're recipient positive, it's irrespective of what your donor is, then you usually give for 6 months. And then we're quite aggressive with investigating patients with community viruses. So anyone with a change in their symptoms or even upper airway symptoms will get a respiratory viral panel. We do a couple of things. I mean, obviously, it's important for isolating it from other transplant patients in the clinic. There are some respiratory viruses that can be treated with antivirals, obviously influenza, but there's some data on ribavirin, which previously was used to treat Hep C, but that it has quite a lot of activity for respiratory sensitive virus, virus V, and human metapneumovirus. So we give that for those viruses. And then, as I said, the viral infections lead to denuding of the airway epithelium and exposure of cryptic antigens. So they often augment immunosuppression during that period. So it might sound quite counterintuitive that you'd give more immunosuppression at the time when somebody's suffering from a viral infection. Usually we give a short pulse of oral corticosteroids just around the time of infection. That's to try and stop the kind of activation of the acute cellular rejection pathway that we can see in patients with viral infections. So this is just a short overview. Just to summarize, and I think I'll let Ashley go on for the next case, but the lung is unique because you've got a constant environmental exposure and impaired clearance, some surgical complications, airway ischemia, and colonization that can occur at the late sites. There's a higher burden of bacterial, fungal, and respiratory viral infections. Just important to notice, probably the most important point is that there's a direct causal link between infection and graft dysfunction. So it's important not only for treating infection, but preventing long-term immunological outcomes. And then prevention and management strategies must be integrated. Yeah, thanks for the time. I hope to take any questions at the end.